and we will email it to you. Maybe by the end of this week, that will be done.
Okay.
Yeah, thank you so much for this great case. So
Thank you.
now move on to Dr. Hatema's presentation. There we go. So this is a disclaimer which states that we do record all our sessions. So if you don't want to be recorded, please let us know and we will be able to edit you out. And the next slide states that Julie already did a fantastic job about this. If you're discussing any case, we encourage not to disclose any PHI. We do not want any HIPAA violations. This is our team for today. And our disclosure policy, which is on the next slide as well, I guess. Yeah, that's it, Dr. Hatema. You can take ahead from here.
Great, thanks everybody. I'm gonna do a turbo didactic today. So last time we had the opportunity to learn a little bit about the rationale for SBIRT and some screening strategies. And today we're gonna focus on the next step in SBIRT, which is the BI. Brief intervention lends itself very well to motivational interviewing strategies, although certainly a brief intervention could be, you're drinking more than is medically recommended and I suggest you stop. But we're going to learn a more patient-centered style of doing that. So this is the SBIRT model. As a reminder, when we screen, we're trying to just quickly get a sense of somebody's risk levels. For patients who are using or drinking at risky levels, they may be appropriate for brief interventions in opportunistic settings like women's health settings, where sometimes just a 5, 10, 15-minute discussion can have a significant impact on health behaviors. But for those patients, likely like the patient that we heard about in the case presentation today that have substance use disorders or comorbid mental health issues, they might be more appropriate for referral to specialty treatment. Most of us, when we think of patients who have alcohol or drug use issues, we really tend to picture patients who are similar to the patient that we heard about in the case, patients with a lot of negative consequences because of their substance or alcohol misuse. And again, these patients really are appropriate for more intensive services. The brief intervention part of SBIRT is really for this group at the middle of this severity spectrum. People who are exceeding recommended limits, maybe or maybe not experiencing consequences, but who are setting themselves up or increasing their chances for risk. And these are the patients that tend to be more responsive to brief interventions like those we can implement in a medical setting. Oftentimes there is kind of this hidden A in the SBIRT model in that if we have a positive screen, we often want to learn a little bit more detail about the patient's drinking through assessment. Somebody may screen as a risky drinker if they've exceeded recommended daily drinking limits once in the last year. We'd be less concerned about a patient who did that last October at their cousin's wedding than we would be a patient who's exceeding those limits every night, for example. Just a reminder that we've done large epidemiological studies to try and make cut points at where the risk really seems to increase for individuals. And so we have these daily and weekly limits. The reason we have these limits, and this information can be used in the context of a brief intervention, the daily limit is really for the acute effects of alcohol. When our blood alcohol concentration gets high or we're under the acute effects of drugs, we're more likely to do things like trip and fall, like miss work or school, get in an argument with somebody that we care about, drink and drive. While the weekly limits are more about the chronic physical effects of alcohol or drugs. So when we use chronically, we increase our rates of cancer, liver problems, etc. So even before we start brief intervention, there's strategies that we can use in the context of screening that kind of lay a good foundation for us to be able to transition into brief intervention. So can you guys think of any patient-centered strategies that might help either people be more open to screening, more honest with screening, or lay a good foundation for brief intervention? And you can just unmute and suggest them if you, what kinds of things might you do when screening to increase its effectiveness?
I like try to normalize that most people do drink, and so that it just getting a baseline and just to kind of normalize it.
Great. Yeah. So we know many of our patients consume alcohol or normal, we ask everybody who comes through the clinic the same set of questions. Great. Other strategies?
Dr. Camera says universal screening.
Yes, so we're not picking people out, and we can explicitly communicate that to patients. We ask all of our patients these questions once per year. How about one more?
Christina says, talk about any reporting requirements or about confidentiality of what we discuss.
Definitely, and I didn't include that in my list I'm about to show, but yes, addressing confidentiality on the front end can help people be informed about what they want to disclose and likely more likely to disclose. So asking permission is a common motivational interviewing strategy. You'll see it a lot today. Would it be all right if we spent a few minutes talking about alcohol and drugs? I ask all my clients these questions once a year. Just agenda setting, letting people know what's coming. Using patient-centered communication, even outside of the context of screening, can help create a therapeutic alliance that make people more open to talking about behavioral health issues. If we get a negative screen, which we will for most of our clients, then we still do a little mini brief intervention, affirm the lack of use or the non-risky use. You still may want to share with clients, what the recommended alcohol limits are and that they not use recreational drugs. Let them know you're here if anything changes and rescreen annually. But if you do have a positive screen, there are 3 steps that are consistent with the motivational interviewing model. The first one is just to provide some feedback about the positive screen. So you might ask permission to share some feedback and then just objectively summarize the results of the screening and assessment. You might want to pick out what might be the most helpful piece of feedback. So that could be, what is their severity level? It looks like you meet criteria for an alcohol use disorder, or you're exceeding recommended safe drinking limits. You may want to connect their drinking to a health issue they're presenting with or struggling with. Tell them about risk for alcohol or drug exposed pregnancy or impact on a fetus if they're pregnant. In motivational interviewing, we love to use this ask, tell, ask, or elicit, provide, elicit strategy when we're sharing feedback or any information. So you might ask the patient what they already know. Then maybe you don't need to share it all if they're already aware. But if you do, you can provide that information in a tailored way. And then, very importantly, ask them to apply that information. How does that impact your thinking about your drinking, for example? So here's an example. Thanks for taking the time to answer those questions. Would it be all right if I shared some feedback about your responses? What's your understanding of what healthcare professionals recommend in terms of drinking limits for women? Listen to the response, reflect it if possible. We recommend that women not have more than 3 drinks in a day or 7 in a week. Since your drinking falls above this level, you're at increased risk for health and social consequences. What do you make of that? And then reflecting their response is an example of a pretty MI-consistent feedback. After we've given feedback, we kind of have a decision to make. So if patients, we can tell by the patient's response to the feedback whether they continue to be ambivalent about whether a change is needed or if they're concerned and want to make a change. If they're ambivalent, we try to build motivation. And if they're concerned and want to make a change, then we collaboratively plan with them about what that change is going to look like. There's several strategies for building motivation. We heard some of these reflected in the case. So having getting to know your patients and what their important goals and values are can help you use good listening skills to try and develop a discrepancy between their values and their health behavior. So it's not us pointing out, you say you love your kids and yet you're drinking a 6-pack every night while they're home. What's up with that? But it's us asking them to reflect on the relationship between their values and their alcohol or substance use, if any, and actively listening to that. Many of you may be familiar with rulers, but you could ask a patient, how important is it for you to cut back on your drinking on a scale from 0 to 10? And it's not the actual number of their response that's important in this motivational interviewing model, but it's what we do with the follow-up questions. So say a patient says, I don't know, a 5, then we ask this kind of counterintuitive question, a 5, why not something lower like a 3? And then we get what does the patient see as important? You can do the same thing with confidence or readiness. With our case, I wonder what a confidence ruler might look like regarding engaging in treatment. I really like this exercise called a roadmap. You might say something like, here we are today and you have some decisions to make about your drinking. You could decide to change and cut back or even quit drinking, or you could stay the same. And here's kind of your life down 2 paths of that river, 2 paths of that road. I wonder what might be some good things down the change road, and you listen and ask follow-up questions, and what might be some bad things down the road where you don't change. You can see that motivational interviewing has this strategic element where you're trying to draw out the patient's own motivations around change. If readiness is high, then action planning may be appropriate. In MI, one of the biggest mistakes we see in this model is that many of us, because we care so much about our patients, are often feel like we have to get to action planning. But it's actually counterproductive to action plan with someone who hasn't decided that there's a problem or that there's a problem they want to address. But if it does seem appropriate, you could test the waters to make sure, sounds like you're really ready to make a change. Would it be all right if we spent some time talking about what that might look like? And then again, you draw out from the client their ideas about who, what, where, why, and when of change. Whew. Thoughts, questions?
Thank you, Dr. Hajema. That was great presentation. Any questions? Please feel free to unmute yourself or use the chat box.
A comment I have on those, us in the primary care office, we screen for tobacco, screen for alcohol, screen for, all these quality measure stuff. One of the things I'm guilty of is not doing anything with that screening, but so I like that you're saying, hey, do something with the screening.
Great. Sounds like you're ready to make a change.
Yep. Oh, I'm in my 2nd year out of residency, so I still have a steep learning curve.
I think, Dr. Dalton, that's such a common reflection back for physicians and providers. We just really are short on time. It's one of our biggest commodities. So, I appreciate the transparency there and the honesty. And I think it is something that we have to determine, even if we're going to do screens, that we kind of are mindful about the message that sends. If we do it and then we don't talk about it, does that send a message like, oh, I put something on there and then no one said anything to me about it, maybe I shouldn't talk about that, those kinds of things. So I think it actually brings up a really good point in the process of implementation.